All right. So we're going to talk about the review of the anatomy of each of the procedures and talk about some of the emergency or acute issues you may see if you're covering an emergency department or have a patient on your service that may have had weight loss surgery, and talk about the supplements and the vitamins. It's an ongoing process. Try to keep you up to date with that. And then a lot of questions about absorption of medications. I'm going to start with some of the common questions I get, even from some of my fellow surgical colleagues, such as patients vomiting. Can we place a nasogastric tube? Another thing we get is a transplant patient or a patient with HIV. What do we do about their medications? And then can they take everything that's out on the market for pain? I've heard something about NSAIDs, not quite sure what that is. And can they have steroids? Let's go over the operations. The Roux-en-Y gastric bypass. Is this a pointer? Nope. Oops, not the pointer. Where's F5? Which one on the side?
It's on the bottom here.
Bottom, right there. Got it. So the gastric bypass is going to take your stomach, divided into two parts with a small egg-sized pouch. We're going to bring up a length of the intestines that's usually anywhere from 100 to 150 centimeters from this roux anastomosis. Usually the biliopancreatic limb is around 40 to 60 centimeters to the old stomach. So it's a shorter course to the old stomach if things are refluxing back up than it is out the mouth. So it tends to take the path of least resistance. So if you're thinking of an obstruction, a nasogastric tube is really not going to help you much here. That'll come and be important later on. Newer operation that's hot right now and on the rise is the sleeve gastrectomy, because a very poorly trained surgeon, unfortunately there are some of those out there, can simply fire a staple load along the curvature of the stomach. So it's a pretty simple operation to do, and unfortunately if you're getting reimbursed for each surgery, doing a lot of these is quite easy, and I'm afraid this is getting overdone. But so this is something you're definitely going to see more and more of. But for the topic of this lecture, really not important because it really doesn't change them too much, although there may be some rapid emptying because of the lack of ability of the antrum to accommodate all this volume. When your antrum gets stretched, it dumps things out. So everything's going to quickly go into the antrum and cause a rapid intestinal transit time, or a decreased total transit time, which may affect absorption of some medications. And then the band, which is fortunately going away, except that actually this morning on my clock radio there was an ad for the guys in Carteret advertising lap band system. But if all you have is a hammer, everything is a nail. The lap band is just a belt that goes around the top part of the stomach. Its Achilles heel is going to be the soft, high dense calorie foods, which is pretty much repetitive. So milkshakes, Mountain Dews, cream potatoes, all that kind of stuff is going to go right through. So again, these are very easy to place. So there's a ton of them out there, and you may see patients on your service or in your emergency room or in your clinic with these, with some complaints. So it's important for us to go over those because of the number of those. So let's talk about acute issues you may see. Start with the band. Most common complication is they've come in for an adjustment and it's too tight and they present with vomiting. About 20% of these will actually slip. Your stomach's moving, slides up through the band. We don't suture the band all the way around because if you fix it the whole way around the stomach, it's no longer adjustable. So it can slip. They can erode into the stomach. Wound infections are usually a sign. If you get an infected port, then that may be an eroded band. So it's in the stomach and it's bacteria migrating up the cord, up the tubing, to the metaport, which is how we feel these things, which is just under the skin. And much like you can feel a metaport, someone that has a metaport on their right by their clavicle, you can feel the metaport on their abdominal wall just by having them do a straight leg lift. So problems with bands is the easiest thing to do is just get a barium swallow and look at the contrast. This is a normal band. In good position, it should have about a 45-degree angle. The esophagus should be normal, and it's one of the problems we're starting to see with bands is that you're getting a presbyosophagus. People are stacking food above it and dealing with the reflux, taking some over-the-counter Pepsid, and they're wearing out their esophagus, basically iatrogenic, self-induced achalasia, if you will, and contrast going through into the stomach, normal. So they're going to come in with severe GERD, intolerance to PO, chest pain, similar to someone who's has no teeth and is stuffed down a piece of steak and they haven't chewed it. It's going to be just hung up there. Huber needle, Huber needle, Huber needle. I can't stress that enough. You would never inject a metaport with a regular coring needle, okay? So there's a difference between the type of needle we use for a metaport, and that's because the hole on it is actually on the side. So when it goes in through the rubber of the port, it doesn't cookie cut punch a hole in the rubber and then you pull it out and then the chemotherapy leaks out underneath the skin, which is a disaster. But if it's in a metaport and you do that, I mean in a band, and you do that and it cookie cuts out, the band will leak out and never be functional again, and that patient's going to be pretty ticked off. So you just let all the fluid out and the band's not there anymore. It's like taking your belt off your pants. It's just, it's done, okay? So they can, if you have a problem with the patient, you need to place an NG tube with a band, just take all the fluid out. So slippage, they're going to come in with severe abdominal pain, and they may at first be able to eat a whole bunch of food because it's sliding up through the band and they have a big pouch above it, and then all of a sudden that stomach will flip over the band and then the stomach's kinked off and they'll not be able to tolerate anything at all. So there'll be a prodrome or a period of time before it flips over or strangles. And here you can see the normal band position, however it's slightly more angular and there's a big pouch above it with food particles in it. It's a posterior slippage. So you really want to make sure that when the stomach flips over the band that it doesn't twist or volubilize and become strangled. That can be an acute surgical problem. Even when they have that, a Huber needle into the metaport, take out all the fluid, and with the band opening up, the stomach will self-reduce most of the time. And they probably don't need anything done more than that. Erosion, they're going to present with acute abdominal pain, maybe fever, a lot of tenderness at the metaport. And then they may also have weight regain because the band keeps eroding through and slides on through the stomach, and then everything can go past the band. Much like a tree that you've seen some barbed wire on from 50 years ago, slowly cutting through the tree and then it's no longer there. The band can actually cut through. That's very rare, but I've definitely seen it. I didn't put many of these in, but I kind of, all I do is take them out and take care of the problems, it seems, from another surgeon in our area. But so if you did an esophagram on that, you'd have a band with no contrast going through it, but just going around it. And you can see how they can have weight regain because the stomach is just rejecting this tubing, but it's not really a rejection. It's because usually it's caused by an injury early on at placement, and it's just slowly eroding through. And for the future gastroenterologist in the room, gastroenterologist, when you scope the patient and you retroflex back, you can actually see the band, and you can actually cut this. It takes a great amount of cussing and a lot of time, but you can eventually nibble through it and actually pull it out. And it's actually better to take it out endoscopically, and it's something that gastroenterologists could develop an easier way to cut this. It'd be a good thing, because you got to think about the omentum is going to come up and cover the stomach and the scarring where the band was placed, and so pulling it out through the stomach, you don't leave an opening into the peritoneal cavity. Whereas if I have to go in through the abdomen, I have to disrupt all that scarring, and then they have a hole in their stomach. So this is actually a better way to do it. And you can cut down on the metaport and bring up and cut the tubing at the level of the abdominal wall, and then the whole thing will come out through the mouth except for the tubing. So you got a patient that presents after 6 months with nausea and vomiting. They've got pain in their epigastrum. This is one of our most common readmissions. Happens about anywhere from 5 to 10% of most gastric bypass patients, but it's easily managed. They're going to come in and they haven't been eating much, haven't been drinking much, so you want to make sure that they're resuscitated, that they're not tachycardic. Check some labs, make sure there's not anything wrong in the Chem7. CBC, make sure they don't have a white count. Then give them a dose of a proton pump inhibitor, see if they have improvement. Always, when I readmit a weight loss surgery patient, one of the first things I write for is a banana bag. It's important because these patients need to be on their vitamin supplementations. They're going to be dehydrated, so you give them some thiamine, some folate, multivitamin ampule, and a liter of saline, and it's amazing how quickly they feel better. Then you set them up for an upper endoscopy to make sure that your diagnosis of an ulcer is right. If not, you may want to get an upper GI to see if there's any kind of problems with obstruction later down. So this is a really bad ulcer, and in preparing this talk, it's for surgeons who do this all the time. Risk is reduced. We deal with it, but for medical professionals that are not doing this, I know weight loss surgery is scary, so part of me had to figure out how to present this to you without scaring you all the way from the operation at the same time. But this part I wanted to scare you on, and that's the use of NSAIDs in these patients. If there's anything you take away from here today, it's just don't do that. It's such a common drug. It's over the counter, and patients will come in with horrific ulcers. And smoking, stress, or this is me taking care of ulcer patients, prednisone, and Motrin. That's just, I hate it. But sometimes you need it. Don't need this. Sometimes you can't avoid that. Definitely sometimes need this. And I'll talk about what we can do to find a nice compromise. So these patients will usually be admitted with a severe ulcer that's not responsive to outpatient therapy. Most of these, 90% of them, come in with these symptoms, start them on some Carafate, proton pump inhibitor, and they do fine. But these drugs have become incredibly hard to deal with on an insurance level. I mean, it's maddening how many different choices there are and how insurance companies differ and want you to justify each one of those choices, but it's completely different with a different insurance company. So we spend a lot of our time writing prescriptions, trying to figure out what insurance company will cover which drug, and then also the cost. So sometimes Carafate is quite inexpensive, sometimes it's $400. So we send out patients with a fair amount of prescriptions that call back. Some of them don't call back, they get fed up, they don't take the medication. So that's one of the problems is compliance. But when they come in, I think the default now in the health span is 8 milligrams an hour. But really 8 milligrams an hour IV really works best continuously. And really once the symptoms have resolved, or pretty 90%, much like you would diverticulitis, if somebody comes in with severe diverticulitis, put them on some antibiotics and they're like, yeah, it's just a little bit tender, you feed them and you send them out. So similar to an ulcer. And it's the same with an ulcer and someone who doesn't have weight loss surgery. Real important to space the Carafate and the proton pump inhibitor out, because the two together tend to cancel each other out a little bit. So oftentimes you send patients out as an outpatient who come back with progression of ulcer disease. It's usually because they've been taking the medications together. So this is what you'll see a lot of, and that's unfortunately patients don't understand the operations, and they just tell you that they've had the gastric, and that doesn't mean anything to me. I mean, when I talk about them at their decision visit, which type of surgery do you want? They say the gastric band, the sleeve gastrectomy, the gastric bypass. Which is it? It's like calling me John. I mean, so raise your hand if your name's John in the room. So it's so a lot of times it's hard to figure out what exactly they've had, and you should try to figure that out. But if a patient comes in with a history of the gastric with abdominal pain, immediately you're thinking, uh-oh, got to call surgery. There's something wrong with their weight loss surgery. But they've had a relief after vomiting. They've had no other associated symptoms. You resuscitate the patient, go through the normal course, CT scan, try to figure out what's going on, check some labs, and lo and behold, it's appendicitis, torsion, ovary, PID. So these patients, just like you can be crazy and have high blood pressure, you can have weight loss surgery and have other surgical problems or medical problems that are causing abdominal pain. One thing you want to watch out for, though, is if they've had a bowel obstruction, a sleeve gastrectomy, you can place a nasogastric tube and have relief of the proximal dilated bowel, because you can get there from here. With the bypass, like I mentioned earlier, it's a shorter course to the old stomach, and they'll get gastric distension of the remnant. So this is referred to as the remnant, and this is the pouch. It's not the stomach that remains as a remnant. This is the pouch. So when the radiologists say the dilation of the remnant, they mean the old stomach that's been excluded. And there's not much you can do about that. Now, if this stomach is incredibly dilated, then interventional radiology can actually put a drain into the old stomach and decompress the patient that way. And that is an option sometimes. But if you don't know, or if they've had a bypass, definitely consult surgery. If you take a job at an outside hospital where there is no weight loss surgeon there, you can always call the nearest tertiary care center and ask to speak to the weight loss surgeon on call to see kind of what you should do. But while we're talking about access to the old stomach, a lot of times we'll get consulted for PEG tubes to be placed in the MICU or the patient who's had a stroke. Unfortunately, in the past year, one of our surgical colleagues attempted a PEG and a patient had a gastric bypass. You can't do that. Okay, this is right beneath the xiphoid process is right here. Okay, the rib cage comes down this way, so you can't put a PEG tube in here. You can place a laparoscopic gastrostomy tube, or interventional radiology can actually place a tube in here as well. But feeding access is possible. It's just a little more involved than a bedside PEG. So we talked about patient who presents with vomiting or small bowel obstruction, and the band and the bypass in the sleeve. With the band, you can simply deflate the band and place a nasogastric tube. The next patient that you may see is someone who's pretty far out from weight loss surgery, and they've come in, not been eating right, not been drinking well, they're nauseated, they feel weak, You want to talk about their urinary habits. How often are they voiding? That's a good sign, a good way to judge if they're dehydrated or not. Bowel habits. A lot of these patients have difficulty with constipation. It may be the types of foods they're eating. It may be they're not drinking enough fluids. It may be that we do a partial vagotomy when we divide the stomach, and it may have some type of disruption of the myenteric plexus. But it's an ongoing problem, and all these issues here can all be related to just being backed up and needing to have a bowel movement. But you always want to ask, are they taking their vitamins and supplements? Because what you don't want to miss is some type of vitamin deficiency or supplemental deficiency that's causing a chronic problem. And a chronic problem with a vitamin supplement or deficiency of a supplement, it can be very difficult to replace. It's a slow process of getting out of the system, and it's a difficult and slow process to get back into the system. And I'm going to segue into vitamin supplementation. So we mentioned banana bags, thiamine, folic acid, multivitamin, and some magnesium sulfate. And usually if you give that, it's going to fix the patient up pretty quickly and resuscitate them at the same time. What we do in our weight loss surgery clinic is we try to see our patients, and are actually required by insurance companies in order to maintain the centers of excellence, is to see our patients annually for 5 years. But you all know that better than I, that patients just don't do that. It's hard to keep them following up. And so this is great for you all to hear this so that you can take this into your practice if they don't come back annually. There are a few practices in the outlying community that we work closely with that have learned this and do a great job, and there's others that we're still working to educate. But this is recommended by the Endocrine Society. So this isn't the surgeons doing this, but we check all this preoperatively. CBC, LFTs, electrolytes, iron levels, B12, folate. Vitamin D isn't on here, but we check vitamin D. Oh, yeah, it is right there. Parathyroid, albumins. We do check albumin. It's amazing how many obese patients are malnourished. And it's just because the types of foods they're eating don't do anything but put fat on you. Bone mineral density studies really should do a better job of doing this one. And vitamin B1 is not a lot of good studies on that, but we definitely see deficiencies in that. We follow most of these first ones. We also check hemoglobin A1Cs if they're diabetics. We check these every 3 months for the first year, and then annually thereafter. Supplements, what we recommend, and always changing, and when we started doing this 10 years ago, we've added more vitamin D, more B12. We switched from calcium carbonate to calcium citrate. So this will continue to change as we learn more and more about vitamin deficiencies and how to better fine-tune the weight loss surgery patient. In general, we want vitamin D of around 1,600 to 2,000 international units daily, calcium supplement in the form of calcium citrate, not carbonate, around 1,600 milligrams a day. 1 to 2 multivitamins. I mean, multivitamins they're just so varied that we just want patients that are going to be compliant. So whichever one they want, 1 to 2 is the best. But these multivitamins don't contain enough, so you have to supplement the supplements with vitamin D, calcium, some iron, and B12. B12 is great. It comes in every form known to man: nasal, dissolvable things on your tongue, capsules, tablets. A lot of times patients want the primary care doctors to give them an IM injection about every 3 weeks. Insurance will pay for that, and it's easier for them to do. It's amazing, and you all probably know this better than I do, how deficient our society is in vitamin D. And when we get these baseline labs on these morbidly obese patients, they come in with a deficiency. So we're trying to tune them up for surgery, replacing vitamin D levels, getting them started on a multivitamin, getting them into the habit of taking these supplements. Iron supplements, again, the multivitamin just doesn't cut it. Menstruating females definitely need to have supplementation in an elemental form. You need to identify anemia in men as well before surgery. These men are going to need it after surgery as well. And it can often be a difficult problem to fix with anemia after weight loss surgery. It's important to add vitamin C to help with the absorption. As far as the B vitamin complexes, really have to watch out for Wernicke's encephalopathy. Patients that come in with excessive vomiting. Dehydration is a vicious cycle. The more dehydrated you become, the more nauseated you become. So you quit drinking fluids. So patients quit eating, vomiting, not taking enough fluids in, they're not going to take their vitamins if they're doing all this. So they could come in a chronic problem. And so, again, the banana bag's going to help boost that up quickly, and you may need to start replacing it. And it'll take a while to get it back in their system once they've lost it. Folate can be a problem, but not necessarily in America. We tend to fortify a lot of our foods with folate, so it's really unusual to have a folate deficiency in our weight loss surgery patients. B12 levels, it's up to 1/3 of our patients can come in with a deficiency, and I've noticed just anecdotally that patients will come in with a normal B12 level and they'll be describing feeling run down. Their CBC will look normal, and they're exercising, they're eating right, they're drinking enough fluids, they're doing everything right, and I'll prescribe an IM injection of B12 and they're like, that did it, and they feel great. And so I'm not quite sure if the B12 level in the blood actually reflects what is actually needed for that particular patient. And that's not all patients, but it's just kind of emphasizes a point throughout this talk, is that there's no real formula. This is a pretty difficult topic to talk about because there's just not a lot of literature on it. But most patients will be fine with just 500 micrograms daily of B12. Vitamin D, really already hit this, but the one thing that's interesting that I found on this article is that, it's kind of a no-duh thing, is that potential explanations for these vitamin D deficiency morbidly obese patients is, they don't like going out. Unfortunately, some of them do, going out in a tank top and short shorts. But so they're not getting sun. We're terrified of skin cancer now. There's no more baby oil and Coppertone being splashed on you. It's all about covering up to go to the beach. We're sitting in a dark room when it's beautiful outside. So the vitamin D deficiency is, pretty much the majority of this room, unless you're taking vitamin D, you're vitamin D deficient. So you're starting out behind the 8 ball, and so it's kind of unfair to say that the weight loss surgery is causing it, because a lot of these patients have it up front. But it can be challenging to replace it, so it's important to follow it. So we'll replace it, and then if it comes back deficiency again, 50,000 international units, get them tank filled back up, and then you want to probably double their maintenance. Iron, but routine multivitamin supplementation does not appear to be sufficient. In most cases, supplemental iron is necessary if they require it. Calcium, calcium citrate, not calcium carbonate. Elevated parathyroid hormone are pretty common, up to 30% in Roux-en-Y gastric bypass. It's unclear if it differs significantly from baseline. So we really need some good prospective studies on all these supplements where we take patients, really study all these vitamins levels in patients, perform procedures, put them on supplements, and see if something really changes. But we definitely have seen levels of bone turnover and decreased bone mass in some of the patients that have been studied after the fact, after they've had weight loss surgery, and then you look at them. So it's not really neat, and this is something Dr. Cook really is interested in, and hopefully when we start getting more patients, we can start getting them into that research project that she's working on. But we don't know if there's really associated fracture rate with this. There are some case reports. Unfortunately, longitudinal assessment of bariatric surgery patients project that ECU is involved with, it's several institutions. When we started looking at fractures, it was very difficult to figure out, okay, was this a pathological fracture, or was this from mineral deficiency, or was this from being 80 years old and had your weight loss surgery when you were 50 and you fell down the stairs, which is what 80-year-old people can do. So the data was just inconclusive. We really couldn't even present it because it was just not good data. The BOLD, which is another database that Centers of Excellence are required, just doesn't even have anything on fractures, unfortunately. So really need a good prospective study where we take patients before surgery, do DEXA scans, PTH, look at the bone turnover markers, and then follow them for several years. And to illustrate the complexity of calcium, there is just all kinds of things going on with calcium and bone turnover, osteoclast, osteoblast. Well, with the diabetes, we're always talking about ghrelin and GLP-1, and then you got the adipose tissues that may be acting on bone formation. Very busy slide. We're not quite sure exactly what is going on in this ball of twine. But the major limiting factor in most of these research projects is that they've been done in rodents, not in humans, and it's not been a prospective trial. So we still need a lot of work on vitamin supplementation. Pregnancy. You're taking all these vitamins and supplements, so you should be good, right? You don't need to take multivitamins, prenatal vitamins. Wrong. And this is another common error I see. Patient comes back, they've had polycystic ovarian syndrome, been trying to get pregnant, and after 18 months, so that's how long we want them to wait, they come back, I'm pregnant, I'm so excited. Are you taking your prenatal vitamins? No, I'm already taking the Bariatric Advantage pill. That's okay, right? No. Those vitamin supplementations are to bring the woman up to be a healthy female. A healthy female has to take prenatal vitamins. So they can't be replaced. You can't just take prenatal vitamins and say this is going to replace my vitamin supplements for weight loss surgery. You got to take them both. So, in doing so, you can get pregnant, you can have a healthy baby, you can maintain your weight, and you're not going to balloon out again. So weight loss surgery is not prohibitive for having children. So what are types of the deficiencies that we may see? Protein malnutrition come in, decreased muscle mass, thinning of hair. I guess I got to eat some protein. But vitamin D, they can come in with hypocalcemia, cramping, metabolic bone problems. B12, pernicious anemia, depressions, feeling tired, run down. That's usually one of the most common things I would see. Folic acid, not seeing a lot of that, but presents with microcytic anemia. Iron deficiency anemia, and vitamin A and zinc. Sometimes we'll see people come in with skin problems. So a patient that I saw, I've seen probably one skin problem that was a manifestation of vitamin deficiency. This was a patient Dr. Porres did, one of his first teenage weight loss surgery patients. She came back, finally kind of reappeared on the radar about 15 years out, had never taken her vitamin supplements, and had thin hair, had a lot of dermatological problems. Got her back in the system. It took months. Eventually the skin problems went away and the hair came back. But really important, because we have issues with compliance and patients coming back. This venue is great to educate more physicians to capture this knowledge and use it on our patients. So let's talk about medications. Are these Frankensteins? Do they need different types of medications, absorption? So in general, our patients after weight loss surgery, the pouch will be swollen. It'll be extra small. They'll be getting used to it. So putting them on extended release metoprolol doesn't work. We've got to put them back on a BID drug that they can crush. If they need diabetes medications afterwards, it needs to be something they can crush. You need to maybe switch them over to some insulin if they weren't on it before, just to get them through the first 6 months where they can take it. After that, they can go to restaurants, they can eat whatever they want that's healthy, and they can take pills, extended release forms. So really, after the 6 months, you don't have to worry about what type of form you give it in. Be careful if you're cutting and pasting in EHR. I know nobody does that, but if you get the HMP from 5 years ago and look at those medications, it's going to be vastly different. Okay. I mean, the goal of this surgery is to get them off of those medications or reduce their doses. So if you're putting them back on their, 100 BID of metoprolol and they're not even on it anymore, you're going to have a bradycardic patient. So be careful with that. So my worst subject in medical school was pharmacology, and I was asked to give this talk. I was kind of dreading it, but P450, okay? So it's the part of your body that breaks down the drugs. It's found a lot in the liver, but it's also found in a great deal of the small intestines, a lot of the proximal small intestines, which is what we're bypassing. So the concern is that you're bypassing the P450, so you're not going to break down the medication, so you're going to get toxic from these, right? Well, these patients also have fatty liver disease. So the fatty liver, the P450 in the liver, is not working so well. So as they lose weight, the liver starts working better, but we're bypassing the stuff in the intestines. So you do this to that. You also, over time, you see an adaptation of the small bowel, right? So if you remember pediatrics, you've got a kid who develops necrotizing enterocolitis. You take out a big chunk of their small bowel. They're on tube feeds for a while, but eventually you get them off of it because their bowel adapts, right? So somebody comes in with an adult with catastrophic small bowel obstruction. We take out part of their intestines. They live on TPN for 6 months to a year, and then eventually we get them off of it. The bowel adapts. So you're going to see initial changes, and then eventually the patient's going to level out. So, but is there a difference in how drugs are metabolized? So this study took 18 subjects that had already had a bypass. So unfortunately, it's not a lot of prospective trials before and after. But then they took age, weight matched, gender matched obese patients, and then also historical controls. And there's the drug cocktail that's used in pharmacology to test pharmacokinetics and pharmacodynamics. And it involves some Robitussin and some Versed and some omeprazole, and some caffeine and some tolbutamine. And they give it its real small doses. But they then can draw your blood and figure out what the pharmacokinetics are of it and also pharmacodynamics. And they looked at Lasix, looking at urine sodium and how much change you have in the bypass patient compared to an overweight, age, and gender matched individual. I hope I did a good job explaining that because it's difficult to understand. But the overall exposure and clearance of the oral medications remains similar to matched controls. You do see that they observed a hepatic P450 activity was significantly higher in Roux-en-Y gastric bypass than matched controls. So there you have it. Your fatty liver disease is messing with your drug problems. We fix that, but then we add a little bit of difficulty with the small intestinal P450. But then you have adaptation of the small bowel. So the literature is really lacking in sufficient quantity and quality of these studies for drug metabolism, and really until we have a good prospective study where we take patients before surgery, run these pharmacokinetic, pharmacodynamic studies on them, and then look at them a year and then 2 years afterwards, can you really, and all drugs are different, all patients' dosages are different, but you really have to just watch them, make sure that the drugs are demonstrating efficacy and not toxicity, and then you adjust the medications accordingly, okay? To give some examples, HIV medications, studies found that the once daily dosing and twice daily dosings of antiviral medications were similar to historical data in a patient who previously underwent Roux-en-Y gastric bypass. So thyroid, sometimes we see some difficulty in the thyroid medications. We watch these because volume distribution changes. We need to watch out that they may not need as much Synthroid. They may need the same, the form of the levothyroxine may need to be changed, such as reported in this study, that they responded switching from oral tablets to a liquid formula. So you just follow your TSH, follow the patients clinically, make sure that they're responding appropriately to the drug. But if you think about if a patient came to you with HIV, came to you with a fresh transplant, came to you with a fresh hypothyroidism, you would watch them, treat them, and bring them back at a short interval to make sure that they're not toxic and that the drug is working. After gastric bypass, we see them every 3, 6, 9, 12 months. We want to make sure that we're watching them because they are a new person. They're very different. They're learning how to eat differently, live differently, and the medications that they were on, hopefully they won't be on anymore, but they definitely will need some changes in the drugs that we're giving them. So back to the common questions. Patients vomiting, can we place an NG tube? Probably won't help. That stomach remnant's going to dilate up, and you may hurt them. You got to be very careful because you may poke it through the anastomosis and perforate them. What about their anti-rejection, antiviral medications? You just treat them like they're a fresh transplant or freshly diagnosed with HIV and watch them for the few months, and they should be back to normal. And what can they take for pain? I love Tylenol arthritis. Mobic if you have to, but I'd probably recommend just an inexpensive proton pump inhibitor. Narcotics, you have to be careful with narcotics and benzodiazepines after weight loss surgery. There are a study that show that because you don't metabolize alcohol and drugs that first pass, these patients get a really good buzz off these medications, much more so than someone that doesn't, but then it quickly goes away. And so initially a lot of the first studies were looking at it an hour afterwards, and we were looking like, oh, there's no change. But then we looked back at 30 minutes, and it was a huge spike, and then it was coming down to an hour and being similar. So alcoholism is a problem in weight loss surgery patients. So we do see patients become alcoholic after weight loss surgery. So watch out for addictive substances that they may be getting a larger spike and buzz off of it. We hope they won't try alcohol because it's calories, and we've known that it does get into their system much quicker, and they can get a DUI after one drink very easily. But for pain, if they have knee pain, you may want to try local injections, some creams on it, but try to avoid NSAIDs. And I wrote in very small letters, unless you have to, really, really have to. Sometimes you do. I mean, if it's an acute injury and they really could benefit from it, then I've had several primary care doctors come and basically make me write a note saying that it's okay for the patient to have NSAIDs. So I think that's great. I think communication is key. I've got a patient that So steroids, if they have to, but really try some alternatives. I would definitely start a BID proton pump inhibitor and probably check them weekly for the first 2 weeks to make sure they're not getting an ulcer. So the patient I was getting ready to talk about is a patient that I share with UNC Chapel Hill's pulmonary group. She has a severe vasculitis of her airway, and she keeps narrowing down her trachea. And they were trying some new anti-inflammatory medication on her, and they were really good about keeping me in the loop, which I thought was great. And so their emails are going back and forth between the rheumatologist and the pulmonologist, and they kept me on all those. And so I was able to say, make sure you put her on a proton pump inhibitor and have her come see me in a week. And sure enough, she came back to see me, and she was starting to have some pain. But fortunately, this drug was a one-time dose, and I put her on some Carafate and upped her proton pump inhibitor, and her symptoms went away and her airway got better. So it really shows what good communication between the weight loss surgeon and the medical specialist can do for patients. So why do I operate on these people if there's risk involved? There are a few challenges managing these patients. Is there an alternative to weight loss surgery? Yeah, you can do a diet and exercise program, but clearly that's not working. We've got an epidemic of obesity and comorbidities related to it. And you have to ask yourself, there's plenty of articles out there on the pharmacokinetics and pharmacodynamics of the obese patient. Weight-based drugs, we under treating them. Are they not getting enough antibiotics for their pneumonia? Or are we giving them too much? Their liver doesn't work properly. A sub-Q injection is not going to work. Who knows what the therapeutic dose of Lovenox is in someone that's 400 pounds. Morbidly obese patients, should they all be tested for sleep apnea? You're giving them narcotics on the floor, and they're not monitored, and they probably have undiagnosed sleep apnea. So should the hospital have a protocol where we monitor all patients who meet your stop bang criteria? So is it risky? Yes. Is there an alternative? Yes. So we put out this study in 1997. Patients matched for gastric bypass. Obese patients underwent gastric bypass, decreased mortality 78%. Swedish obesity study. It's like the Framingham study for overweight people. Randomized people to surgery or controls. Controls had a cumulative mortality rate greater than surgical patients. In summary, these patients are not the Frankensteins that you think they are. Just try to avoid nasogastric tubes. Try to avoid ulcer-causing medications. Check your drug levels and treatment markers, such as viral loads, or check your cell sup if you're transplant patients, if you can. And just remember that obesity is the Frankenstein we're trying to get rid of here. Any questions?
So John, first a question and a comment. If you do the gastric sleeve, what happens? Do you still have the same vitamin issues or not?
Well, so they've done studies on transit time, and it's some type of radiological procedure, but basically they can give you a substance and time it, and the transit time is shortened after sleeve in the gut. So it's basically a physiological bypass. So the gastric bypass works because you bypass the duodenum, and we don't know exactly what's going on, but we know it helps. And we're seeing more diabetes remission than you do with a band, and we think it's because you're dumping things and it's just zipping through that area. It's not having enough time to contact with the cells, or you're going down to the hindgut and you're getting a lot of the hindgut stuff like peptide YY that's coming up. So you do have something going on of a metabolic component with the sleeve. So I think until we have good long-term data, I treat them just like a bypass patient. They go on all the same vitamins and supplements. I mean, you're taking a big chunk of the stomach, so you know you're losing intrinsic factor. And if they say it works great for diabetes, well, there's got to be a con to that as well, and I think that's malabsorption.
On the comment on the B12, so in the neuropathy literature, we know that the B12 level of 250 is definitely wrong. It's got a normal of at least 400. You can double check with methylonic acid, unless it's going to be wrong to do it. So I think using the standard they have, they're actually wrong. We should have a higher level. The other problem is a lot of diabetics on metformin. We know metformin decreases B12 absorption in neuropathy associated with exacerbates metformin. Many diabetics are on metformin.
So when you check a B12 level and it comes back normal, don't believe it. Right. And homocysteine will help you.
May, methylonic acid, yeah.
Okay.
On the NSAID question, why do you pick Movic over the others?
It's just a kinder, gentler, and I don't know the pharmacokinetics of it, but I don't see as much ulcer problems with it.
And a corollary to that is some of my patients come back and say they've been told no NSAIDs for 6 months. Others come back and say they've been told no NSAIDs for life. It sounds like for you it's no NSAIDs for life.
I know early on, it's very strict as that area is healing and it's the gut adapts. When I go back and scope somebody who's a year out, the intestine lining looks different, and the cells have changed. So I think it's a little more. I mean, think about it. The jejunum, how is it so different from the duodenum? So what? But I think that you get what one of these articles describes as a neoduodenum. So you it starts changing into it. And I think it gets a little bit harder and may be able to take some NSAIDs. So that's why I'm saying you have to.
So since I treat a lot of headache, if we keep them limited to once or twice a week, is that limited enough or even less than that?
If you're going to do it, just watch them and counsel them on. You may get an ulcer, and when I have a patient come in preoperatively with migraines, it is I may, unless they have severe diabetes, I may push them towards, and the sleeve is great to have in our armamentarium because with patients that are going to need NSAIDs, then it's a great option for them. Okay, unless they're a sweet eater. If they're a sweet eater, then the sleeve is not going to help them that much because they'll just keep drinking Mountain Dew. But for someone with migraines that's going to need NSAIDs, or someone with, say, sarcoid, it's going to need prednisone, then I may recommend a sleeve.
How do you get people to absorb each of them fully? Like you said, with iron, I have a hard time. We end up using a lot of IV iron.
Yes. I don't know why that is, why some people, because why isn't it that for everyone? I mean, we know vitamin D and calcium is a problem for everyone, but iron is just, and I think that's because we don't study them preoperatively as well as we should. I bet those patients probably have an underdiagnosed that's just, I bet if you look back, their CBCs show kind of the lower end of where they should be. And so I wonder if there's a way we can ferret out the ferritins and see what's going on beforehand. What do you think? You think there may be some underdiagnosing of that?
Yeah, I mean, I think that women have a lot of blood loss from menses.
Right.
And they get pregnant and they have worsening iron deficiency.
But there's some severe, and why it causes such bad ulcers, I don't know why either. Because when we have to really jack up the iron levels, the ulcer rates increase, which I don't understand. I guess it's something in the formula.
There's also some descriptions of copper deficiency that maybe the microcytic anemia that
Right.
mimics B12. I mean, I haven't seen, I've been checking a lot of copper levels.
The copper, about 2 years ago, that kind of came on the, I think about 2 years ago, everybody started getting interested in these micronutrient deficiencies. And copper was one of the first ones that kind of came up. And again, we don't, a lot of these trace metals and micronutrients, we don't have ways of following them, and it's difficult to say what is the right level. And I think only time and just watching the patients. Unfortunately, it's not something that's happening suddenly, and but a lot of times we will just tell them to take 2 more multivitamins if they're having some problem, some type of numbness, tingling, feeling run down that we can't explain by anything else. Then we just say, okay, it's a fibromyalgia. It's a diagnosis of exclusion. We ruled everything else out before and then we just start them. So hopefully time will tell.
Thank you, John.
Sure.